Morning, ladies and gentlemen. Welcome to this session. My name is James Mpunga. I'm co-chair to this session. My colleague is...
Hi, my name is Catherine Horton. I'm from the London School of Hygiene and Tropical Medicine.
Thank you very much. This session, we'll discuss about the priorities in identifying missing cases. I think all of us are aware that the national TB control programs continue to miss a lot of TB patients due to a host of reasons, be it a cost on the health systems, on our patients themselves. We are talking now about catastrophic costs, issues of access to care in our countries, issues of reporting challenges, whether it's data recording and reporting, interventions probably that we need also to think again, talking about active case finding, passive case finding, and seeing the difference in terms of the effectiveness of each method. So the presentations that we have today, I think will take us through some of the challenges that we meet in the health sector as we are trying to make sure that we find these missing cases. Colleagues, I think you know that we have carried out a number of prevalence surveys in most of the countries, and we continue to see a lot of missing cases. The notifications, compared to the prevalent cases, they're usually very far apart. So I welcome you to this session. We are going to hear from 9 presenters, and we hope by the end of the 1.5 hours, we should be able to address most of the issues that we have. Can I turn over now to Catherine to call the first speaker?
Certainly. I will also add a brief administrative note. Because we have so many speakers in this session, we would really ask that our speakers try to stick to time, keep their talks to about 8 minutes so we have time for a question or two at the end. We will give you a signal at 7 minutes and again at 8 minutes so you know how you're doing on time. I'd like to invite Fintabil Getnet to the platform to give our first talk today. If he's here. No, not here. All right, then we will move. We'll move straight into Michelle Kahn's talk. Michelle's going to be speaking about prolonged delays in diagnosis despite availability of free healthcare services in China.
Hi, everyone, and thank you for sticking around until Saturday. So as the title of my talk gives away, we looked at delays to diagnosis and found that there were prolonged delays. And what I'm going to tell you about is how we did this study and why we think that delays can be very important even when countries are performing very well on targets. So I know this is very familiar to everyone here, so I'm going to go through this quickly, but just to emphasize that, of course, the TB control strategy is based on the case detection and cure targets, and this study was conducted in China, which is doing extremely well on these in the 90% and above. And of course, just to take a step back and reflect on the fact that even when we're talking about DOTS coverage, which many countries, including China, are reporting 100% at, it's really just, when we say 100% DOTS coverage, it's important to remember that we mean that the population has access to a facility in and around the region or the area that they live, but it's not necessary that all patients with a cough are seeking care there. This is a chart that I really like because it helps to highlight that despite the fact that we put in a lot of effort in reaching the 70% case detection targets, we're still not seeing the sort of incidence declines that are expected. So this is at the global level, but again, the story is the same for China, particularly Western China, where the case finding and treatment success rate is very high, but they haven't seen a decline in incidence. So it really raises the question about, have we as a global community set the right targets? And if so, why are we not seeing the declines in incidence that we are expecting? And you see the blue line is what we should be, what we're hoping to achieve in order to reach the 2035 goals of a 90% reduction in incidence. So we're a long way away. So in answering the question, do we have the right targets? Well, I would argue that actually we've missed something that's very important, which is delay. And the reason that delay is important is because delay is most directly linked with transmission. So if there's ongoing transmission, then it's not surprising that when we look at incidence rates at the end of a year or at our next surveys, we're finding that we've had a limited impact. But programs tend to focus on percentage of new cases detected because that's the way that the targets are set. And there's very little routine monitoring of delay on a large scale. So this study in Yunnan province, China, is a very important one, we believe, because most of the delay studies that have been done are rather small, and there's a lot of bias because they're facility-based and they're quite expensive to conduct. So just to give you a bit of background, a systematic review that was conducted in China looking at all previous delay studies found about 34,000, in their meta-analysis, they had about 34,000 patients' data that they could include. This study, because we were using the routine electronic reporting system, is the largest study that we're aware of on delay, sorry, I skipped, which included over 76,000 patients. So it's more than double the meta-analysis that included all studies that have been done so far. To give you a bit of background on the electronic reporting system, so every single TB patient that is diagnosed and treated under DOTS at the Yunnan CDC, so basically anybody who's getting free standardized treatment goes to one of the CDC centers. There's over 180 across the province, and all of them have the same electronic reporting system, which is what we worked with in collaboration with our partners. And we calculated delay at three stages. So the first stage is between the self-reported onset of symptoms and the first time a patient reached a doctor at the CDC center. So not any other healthcare seeking encounter that they had, but actually the first time they reached a center where they could get free standardized services. Then the next stage was between patients' first contact with the doctor at a CDC center and how long it took them from that point to have a confirmed diagnosis, and then between confirmed diagnosis to treatment initiation. So we wanted to see whether a prolonged delay occurs even when there's 100% DOTS coverage and the treatment success rate is above 80%. I'm going to skip through this, but because the results are quite simple, but just to say that we received this massive database in Chinese with hundreds and thousands of patient records. So there was a very lengthy process of cleaning and analysis that went into this, and it really was only possible by working in collaboration with the CDC. So these are our results, and it's very, very. There was a very clear finding. By far, the longest period of delay, 57 days being the median, was at the very first stage between onset of symptoms and reaching a CDC center. Don't think I can point with this. Once patients had reached a DOT center, it took 2 days for them to have a confirmed diagnosis, and then after they had a confirmed diagnosis, only 1 day between that and starting treatment. So these are the medians. So you can really see that the delay is very much at the first stage of accessing the appropriate facility. And we looked at prolonged delay, which the Yunnan CDC defined as over 90 days between symptom onset and reaching a health facility, and 32% of patients experience a delay of more than 90 days between reaching a DOTS facility. So what can we, some of the reflections on this. So again, just to emphasize that what this showed is despite the fact that there was 100% DOTS coverage and free services and the case detection rate was being reported very high year on year, we found that there was a prolonged delay between accessing health facilities that were providing standardized treatment. And there have been other studies done in Yunnan which showed that this does result in ongoing transmission. So when contacts of patients who've had a prolonged delay were traced, there was much higher likelihood of them being infected. And this begs the question, well, do we then need to invest more in active case finding, perhaps, because patients are seeking care, but seeking care elsewhere. But the other side of that is that active case finding often targets patients with very clearly defined TB symptoms or contacts, and often patients don't know that they have TB and they are seeking care, but in the private sector or even in other public health facilities that aren't providing DOTS. So we have to weigh out the pros and cons of going for a continued vertical approach or actually working more broadly within strengthening primary healthcare services. And finally, the big question is, do we need to start including delayed diagnosis as a routine indicator? Because as I hope this example from Yunnan Province, China shows, national programs can be functioning very well as far as the global targets are concerned, but still patients can still be experiencing very, very long delay, and then programs are concerned about why they're not seeing declines in incidence even when they're meeting all the targets. Yep, thank you.
Yeah, we now open the floor for comments and questions. Maybe we might take 2 or 3. She's within time, so we can take 2 or 3. Yes, at the back.
Thank you. Great presentation. Pren Maidu, South Africa. I was just wondering whether these only included cases that actually initiated on treatment, and whether you had any quantification of the proportion that did not initiate, and whether delay was associated with non-initiation.
Yeah, that's a good question. So it was patients that had confirmed smear positive TB diagnosis and adults. And at least in the records, there wasn't very much loss following diagnosis. And as you see, even the time period was very quick. People were being put on treatment within a day. I think that's really down to the fact that there's a very good tracing system in China. So it was, in answer to your question, it was people who had a confirmed diagnosis, not necessarily those that started treatment.
Another question.
Good morning, Andrew Medina Marino from South Africa. So with the delay that you're seeing, could you elaborate a little bit more on, is it personal health-seeking behavior reasons on why they're not showing up for so long? Is it a structural issue? The facilities are very far away, they can't get to them. Could you just elaborate more on that?
Yes.
And how many of those individuals that didn't show up, do you have any sense of if they were household contacts, such that if active household case finding was occurring, that they would have been picked up earlier?
Okay, so in terms of some of the reasons, we did look at using the database, what sort of factors, socio-demographic factors were associated with a prolonged delay. That was one of the only data, because this was a routine data set, so we were limited in how much sort of depth of data we had, but we did find that patients who were non-residents, classified as non-residents in the province, so migrant workers, appeared to have a longer delay. So part of it appears to be with accessing, even in terms of medical insurance coverage and concerns about having to pay at the facilities. So that's one reason, but also because patients can only get free services it was about 186 centers across the province. So even if they're going either to a private center or a government center that's not affiliated with the DOTS program, they don't enter the system, and that causes a delay as well. And sorry, and your second question was?
If this is a routine data set, you probably can't answer it, but is there any sense of how many of these individuals were household contacts of known cases, such that if household contact tracing were occurring, the system would have picked them up earlier?
Yeah, I can't, no, I'm not sure about that, but I know that they are beginning to track that as an additional strategy, and trying to compare household contacts versus actually screening more actively in other public health facilities, for example.
Thank you, Michelle. I'm very sorry, but we're short on time, so maybe you can ask a question afterwards with Michelle. Could I please ask Rachel Force to come up to give her presentation on a strategy to improve TB screening in South Africa?
Okay. Good morning, everyone. My name is Rachel Force, and I work with Interactive Research and Development in South Africa. And I worked also with the Orm Institute on this project in Ugu District, which is in KwaZulu-Natal, South Africa. So a little bit about the setting. As you probably all know, South Africa has a very high incidence and prevalence of TB, along with high rifampicin resistance, so a lot of MDR cases. It also has a high HIV prevalence. So Ugu District is based in KwaZulu-Natal. It's on the eastern coast of South Africa, south of Durban. It has a population of 722,000 people, and the government estimates that it's 76% rural. So before we began this project in 2014, the government estimated that the incident rate in Ugu was 1,096 cases per 100,000. So it's very high in terms of the burden of disease. Okay. So we employed two strategies in this program. The first was facility-based screening. So we recruited volunteers who had been volunteering at the clinics. We trained them on an app and how to screen for TB, how to collect sputum samples. So there were 81 total facilities in the district. We chose all of the hospitals, the secondary care centers, the CHCs, and primary health care centers, and we worked in 19 of those. We screened it in the mornings at the highest volume hours of the clinic. And so the screeners would meet with patients as they came in and systematically screen everyone who came into the OPD. And then if anybody had a symptom or a risk factor, they were asked to produce a specimen on the spot. All of those samples were then registered at the clinic through the National Department of Health and the NHLS system. So the government performed all of the sputum testing. And then if anyone was found to be positive, they were initiated on treatment at that facility. The second strategy was community-based screening. So what we did is we went to different areas and we recruited volunteers. We found that it was best to do what we called elimination campaigns, which were 30 days intensive screening where we did some mass mobilization and also door-to-door screening. So because Ugu is a very spread out district, it was quite difficult to do a lot of the mass mobilization in many of the regions. Some of our health screeners would walk up to 2.5 hours to go collect sputum samples and then bring them back to the clinic to deliver them so that they could be tested again through all of the normal government testing facilities. Clients were then all notified of their results, and if a patient was found to be positive, we assisted them to get to the nearest facility to initiate treatment. So we did a lot of this work through an mHealth application. So this is an Android app, and so we gave the screeners phones, and we were able to collect everything that's collected on the National Department of Health paper screening tool. So this includes demographic information, symptoms. We added some additional questions, so symptom duration. We collected contact information, and then we were able to understand if that person was a presumptive TB case and if we needed to collect a sputum sample from them. So the app will tell you, you need to collect a sputum sample or go to the next patient. We could then record when specimens had been collected. We could also scan the barcode on the lab form so that we could have a unique ID for that sample. We recorded all of the results, and then we could also track when patients were initiated on treatment. So this app can take from screening all the way through treatment initiation and then all the follow-ups through cure. We also created short sputum instruction videos. So they came in 5 languages, and the character on the right was the main character who showed patients how to breathe in and out deeply, how to cough up a sample, how to produce a good quality specimen. We made 2 versions in each language. So some are for cell phones, and it's a shorter version that teaches the patient. And then there was a longer version that could be put on the TVs at the clinics, and it could run on a loop, and it explained a little bit more about TB transmission. We also made subtitled versions because, especially in the other district where we ran this, we had a lot of MDR TB patients who had some hearing loss, and they needed to be able to read it. I'm going to go through this quickly, but we paid some performance-based incentives in the facility and in the community. So in the facility, each health worker was paid a base stipend. And then we provided incentives on a monthly basis. So if they screened a certain range, so you can see, oh, I guess it doesn't point. Okay, so if they met their targets, they would receive like a different amount of money. I hope that's clear. And then if they collected a high percentage of sputum, and also we incentivized data quality. And then in the community, we paid a daily rate if screeners would attend work and they would go out into the community and begin to collect the sputum. If they screened more than 30 patients a day, and this could be very difficult if they lived in quite remote areas, we gave a bonus. For each sample, we paid a small amount, which basically just covered the transportation to the clinic. And I should note that they were only paid if they were given a positive or negative result back from the government. So if they were just providing saliva and it was rejected by the lab, they wouldn't receive the payment for that. And then if they got a positive case notification with treatment initiation, then they were paid a larger amount. Okay, as for our results, the facility intervention lasted 6 months longer than the community intervention, and we screened over 100,000 people in the facilities, about 14,500 in the community. So about 34 to 38% of people screened had a symptom or a high-risk factor. And then we were able to collect sputum samples. So in the facility, you'll see 59% is slightly lower than we would have hoped. And this was really because in the hospitals, many of the patients did not want to get out of the queue because they had been referred to the hospital. They had sometimes traveled several hours to get there. And so they didn't want to provide samples on the spot. But you can also see that in the community, when you incentivize sputum collection, they really go out and make sure that those samples are collected. From this, we found 1,482 cases in facilities, 173 in the community, and treatment initiation rates were 94% in facilities and 92% in the community. Okay, so in conclusion, I think we've shown that an mHealth app combined with performance-based incentives can improve health screener efficiency, sputum collection rates. Sometimes when you show the screeners, how they can earn money through the incentives, it really does allow them to self-direct their work and maximize TB detection. And it also, and I think this was the real thing that we learned, having the data in real time, knowing exactly what's going on at a site that's a 3-hour drive away can be very useful, not only for our program, but also for the Department of Health, because sometimes there were long delays in providing that information to the government. And then the dual strategy of systematic screening in health facilities and active community case finding detected many patients who had been previously missed. And lastly, we shouldn't just limit these kind of innovations with mobile phone technologies and videos to urban areas. I think it's really, for us to find the missing cases, we really need to go out into the rural places as well. So I'd like to thank our donor, which is TB Reach and the Stop TB Partnership, again, IRD and the Orm Institute. And this project couldn't have been done without a lot of M&E support and mainly the implementation team that was based in KwaZulu-Natal. So thank you.
Thank you very much, Rachel. I think we probably have time for a question.
Thanks. Steve Neary from Project Hope. Rachel, thanks very much for the presentation. That looks like a really interesting program. My question is, do you have any way that you can tease out the difference between the mobile app and the performance-based incentives and the results that you got?
Yeah, so we can do that because in the beginning, the facility-based screeners were using the app, but we hadn't incentivized them. And then we said, okay, we're going to give you some incentives, and we showed them how it would work, and performance really did improve. We saw that in the first month that we gave the incentives, they were in the lowest range for like sputum collection and also for screening. And then over time, everyone got into the highest range. So you can measure that, but I don't have the data on me right now.
Hello. Thank you for a very nice presentation. I'm Dr. Shalim from Bangladesh. Among the diagnosed cases, this 1,462 or something like that,
Yeah.
what was the delay in diagnosis among these patients, those who are diagnosed?
So all of the testing happened on GeneXpert, and we know that from...
I mean the patient delay, actually, patient delay. Because in earlier presentations, say, for example, we have seen 90 days average delay from symptoms appears to diagnosis.
Yeah, so our target was to get patients on treatment in 3 days. And so on average, we were able to do that. So from them presenting at the facilities or collecting the sample in the community to testing, it happens pretty much the next day in South Africa on GeneXpert. And then the results are sent back to the clinics. That can cause a bit of a delay. And then we help the patients get to the clinic for treatment.
I think my question did not get
I think
clear.
the question may be
Sorry.
asking whether you collected information about the delay from the time of onset of treatment onset of symptoms to seeking care at the facility.
No, we
or to
didn't
being
collect that,
detected.
sorry.
Oh, thank you very much, Rachel. And I think just for the sake of interest, Rachel, before you go out, what would be the advice that would give you to national TB control programs that would want to take this on board? Should they start with a mobile app first, or like you did, or we can start both?
Sorry.
Like Steve did ask the first question. I think there are two things here: the mobile app plus the incentives.
Right.
So supposing an NTP wants to probably start this in their country,
Right.
what would be your recommendation? To start with one or to start with both, the app plus the incentive?
So in South Africa, the app works very well because we have good network coverage. I would say to start with the incentives if you don't have consistent access to network, because it's really helpful to use the app if you can track it in real time. But if you're going to face a lot of systemic problems, then I would see how the incentives work. But also know that with incentives, you might get a reaction you're not expecting, and you might need to be able to change them as you move. Yeah.
Thank you very much. Yeah, we'll take the next presenter, it's Dr. Noreen. Dr. Noreen is going to present on engaging the private healthcare providers in Pakistan to increase case detection.
Thank you very much. Good morning, everybody. I will straight away start with the presentation, not to lose any time. As the title suggests, I'm going to present our experience over the last five to 7 years engaging private healthcare providers in Pakistan to increase case notification. Just a little bit on Mercy Corps. We've been in Pakistan since 1986, and since the beginning of 2000, we have been working with the local populations, with main emphasis on TB control, which is our largest program, funded by the Global Fund, and also emphasis on maternal, neonatal, and child health, youth programming, and economic development. Currently, we are working in over half of the country. The country is pretty, it's a big country. We are working in 80 out of 140 districts of the country. This is just to show the geographical coverage of our programs. Pakistan has a very high TB burden. It has the 5th highest TB burden in the world. Each year, more than 500,000 people develop TB in the country. In 2014, Pakistan notified over 300,000 TB cases, which means around 40% of the cases were potentially undiagnosed and untreated. And although case notification over the last few years has really increased, but there's still a large percentage of missing cases, which, as you can imagine, is a great cause of concern because most likely they're either not diagnosed or not properly diagnosed, do not receive quality care, and will often face a long delay before they're diagnosed. We also know that majority of Pakistani population seeks healthcare in the private sector. The National TB Control Program and its partners long ago realized that without involving the private sector, we cannot expand the TB services, and we cannot find the missing cases. And we are most concerned about delay in diagnosis, inappropriate or poor diagnosis, or incomplete treatment that could result in drug resistance. Pakistan also has a very high burden of multi-drug resistant TB. So in 2011, Mercy Corps started PPM interventions, public-private mixed interventions in Pakistan on a large scale. And over the years, the program has implemented several strategies, has modified several strategies to streamline TB case management and reporting in the private sector, which really is a very, very challenging area. Given that there are currently no regulations, or even if there are regulations for the private sector, they're not really being implemented. The private sector providers really function on their own, can implement any sort of guidelines or treatment regimens that they want to follow. Currently, we're implementing the program in 75 out of 140 districts of the country. Now, these are mostly small to medium to large districts. They're not big metropolitan cities. Over the years, we have implemented interventions in large metropolitan areas and other districts, and then we have handed over several components of that program to back to the National TB Control Program or to other partners. So currently, starting July 2015, we are working in 75 medium-sized districts. And in case of Pakistan, medium-sized can really be a population of up to 1 million, a lot of which would be rural population. Our key strategies included, and I really want to highlight this, that to implement a TB control program in the private sector, you have to have buy-in of all of the stakeholders, and especially the national and provincial TB control programs, but also associations of private practitioners and other technical stakeholders to agree on how the program will be implemented in the private sector, what guidelines, what reporting mechanisms, how that data will get included in the national reporting system, and a lot of those details have to be worked out at the onset of the programs. And it took us almost a year to have all these details agreed between all stakeholders and then implemented. Then we map private providers in the project districts. Based on a selection criteria, we select them, but then through ongoing discussions with them, we sign a memorandum of understanding so that the role of different partners, especially the district TB control program, the implementing partner, and the private provider is clear. We deliver a standardized training program across all these districts for the private providers and the lab technicians. And then the most important component of the program really is consistent follow-up with those private providers, because for them, because they have large OPDs, a large number of patients that come to them, they don't have time to fill all those lengthy records and registers that need to be filled for TB case reporting. So you really have to support them in that. And then quarterly, we do a data review and validation meeting along the same lines as is done in the public sector, so that all that data can flow into the national reporting system. We're also doing combining this intervention with active case finding through chest cams, which is mainly being done through sputum microscopy, and not at a very, very large scale. And as of July 2015, so about a year ago, we have added incentives, because over the last few years, we were seeing a lot of effort was going into this program, and the results that were coming were fairly limited. So we have added very small incentives for the general practitioners who participate in the program and the lab technicians. In terms of results, from January 2011 to December 2015, we have reported almost 70,000 all forms of cases. But more specifically, from July 2015 to June 2016, in 1 year, we have from 75 districts, we have reported 24,000 all forms of TB cases with a treatment success rate of 93%. And I also want to highlight that for these 75 districts, the contribution from the private sector providers was 12% of the total cases notified in that 1 year period. I'll just show you a few graphs which I've separated by time period because different interventions were implemented in different districts during this time. So in 62 districts, we worked from 2011 and 2014. And I'm showing you here data of bacteriologically positive cases only because for the first 2 years, that was the data we were reporting. I hope you can see the green line, which was the ppm data. So in 2011, when the program started, of the 80,000 cases that were reported, only 600 were from the private sector provider. Like I said, it took us a year to really set up the program in these districts, and it was on a fairly large scale. But over the years, you can see that the graph is going up, and the numbers reported by the private sector providers is consistently going up. And it is almost proportionate to the increase in the total number of cases that are being notified in these districts. So it clearly shows that the interventions that were done with the private sector were actually adding on, providing additional case notification to the public sector system. From July 2014 to June 2016. So here we are comparing July to December 2014 data with July to December 2015 data. In 2014, we were working in some of these districts, so some small-scale PPM interventions going on. In July to December 2015, we were setting up services in all 75 districts. We have compared the data, and clearly with the scale up of PPM interventions, there's an increase in case notification. The last two bars are Jan to June 2015 and Jan to June 2016. Here, our program was really well established in Jan to June 2016 in 75 districts, and there's a huge increase in the cases notified. If you compare the two time periods, Jan to June 2015, we had about 8,000 cases notified by the private sector, and in Jan to June 2016, the number doubled. This is the case notification trend with the base. We have taken July to December 2014 data for the whole district, public and private sector combined, as the baseline. And in Jan to June 2016, when our services were well established in all 75 districts, you can see a huge increase in the cases notified by the private sector. So in conclusion, the project data clearly shows that there's an upward trend in case notification in the project districts where we are working with the private sector provider. I think I forgot to mention that we are working with about 2,000 private providers in these 75 districts. Clearly, there are additional notifications that are being made by the private sector and the public sector. So overall, national data, reported data for those districts is increasing over the years. And with continued efforts and collaboration with the private sector, the number of notified cases is increasing. In terms of recommendations, we are, so understanding the private sector in Pakistan is really important because these general practitioners are mostly clustered in certain urban areas. So you really have to expand and increase your network of providers, especially going into the sub-district level. So increasing the number of private providers is really, really important. Introducing newer technologies, which we are currently not implementing in the private sector, such as digital x-rays on active case finding, or Gene Expert in the private health facilities. We are now starting a pilot in 6 districts for both these interventions. Using technology for ease of data collection and reporting is hugely important in the private sector. Like I mentioned, for private providers to fill those registers is a huge challenge. So we are doing a pilot in 4 districts for a mobile health application. And finally, having legislation and regulations which are supportive, conducive for the private sector to start reporting data to the national system is hugely important. So thank you very much.
Thank you very much. It's really interesting to hear about the work engaging private sector. I'm afraid we probably don't have time for questions as we need to move on to our next speaker. but perhaps you could speak after the session.
Okay, thank you.
Our next several talks are going to focus more on contact tracing. Could I please invite Sandeep Baraswadkar to come and speak about his experience with a study in India?
Friends, today is Deepavali, a major and famous festival of India. Before I start my presentation, I would like to take an opportunity to say Happy Deepavali to all of you. Thank you. It is aptly said that there is no such things as no contact. And recognizing the same, we undertook this study of impact of contact tracing of smear positive TB cases on annualized TB case notification rates in India. On behalf of all my colleague authors, I would like to discuss some of the prominent findings of this study. Contact tracing of smear positive TB cases is recommended by WHO and is part of policy and guidelines of National TB Program as well. In Maharashtra state, this has been implemented as a policy. So we made an attempt to assess the impact of contact tracing on annualized TB case notification rates in India. Maharashtra is a big state, population of more than 112 million cases, 112 million. All smear positive TB cases registered in 2015 were included. All staff were trained in the principal and standard operating procedures for contact tracing. We do have recording and reporting formats in place. For example, TB treatment cards and TB registers that were utilized to capture the data. And prescribed formats were utilized for reporting purposes, and the data was analyzed at state level. What we found is that in 2015, 64,960 TB patients were registered, and contact tracing could be done for 94% of the patients, that is 60,839. Out of those 60,000 odd patients, we found 225,000 contacts, that is average 3.5 contacts per smear positive TB patients. And out of those, 19%, that is 42,627, were presumptive TB cases. And 7% out of them, that is 2,825 TB cases, were found out of this contact tracing exercise in year 2015. If we disaggregate these contacts in terms of adults and pediatric, we found that 42,000 out of these 225,000 were pediatric contacts, and 955 TB patients were pediatric TB patients out of this contact tracing. So, for each smear positive TB patient, we found around 3.5 contacts. So for adult age group, for each smear positive patient, 3 contacts, and for pediatric contact was less than 1. Maharashtra state registers around 120,000 TB cases annually. So contribution of contact tracing to total case notification rate was around 2%. The remarkable finding was that contribution of contact tracing to pediatric case notification rate was 14%. So Maharashtra state had 6,877 pediatric cases in 2015, and 955 out of them were pediatric. And number needed to test is 15. So when we tested 15 presumptive TB patients who are contacts, we found 1 TB case. So we conclude that considering the chain of transmission, contact tracing remains an important tool in improving case notification. Contact tracing results in improved case notification, adult as well as pediatric. Systematic implementation and routine capturing of data remain key to strengthen TB notification through contact tracing. Fortunately, Government of India had come up with revised technical and operational guidelines which do captures this contact tracing data in real time through a web-based portal, and we do have a system in place of capturing the data in records as well. The present study, of course, was conducted for patients in public sector, but because the data for contact tracing of privately notified TB patient is not currently available. Though e-Nikshay is in pipeline where the data pertaining to public sector as well as private sector would be captured, but that would be quite interesting to know the yield of such efforts for privately notified TB patients as well. Thank you.
For the presentation. Very interesting indeed, the contribution of active case finding, I think, on contact tracing to the pediatrics especially. 14%, I think that's amazing. We open the floor for questions, maybe 2 or 3. Oh, that means it was very clear. Thank you very much, Sandeep.
Thank you. Thanks.
We'll proceed with your program, and the next presenter is Dr. Hamim.
Or maybe Dr. Mohammed Khalid?
It's not here.
No one from Afghanistan? No.
Okay, so we move on. The next presenter will be how do you pronounce that? Mutesanda? Mutesasi, yes. Thank you so much. He's going to present on active TB case finding using contact investigation in a more efficient approach compared to the targeted community TB screening outreach. Thank you. You have the floor.
Sorry, just a moment. We'll get the correct presentation, please. If we could move to the next presentation.
Yep.
Great. Thank you.
Thank you, and good morning, everyone. I'm going to present the results of a comparison of 2 active case finding approaches for work that was done under routine program settings. I acknowledge the authors and their affiliations, and I have to mention upfront that at the time this work was done, I was the Deputy Project Director for the project I'm going to talk about. So very briefly for the background, I think I've been discussing TB case finding in resource limited settings, and the finding that it is predominantly passive kind of case finding, relying on the self-reports and the patients showing up. In Uganda, as a result of this, we note from the prevalence surveys that only about 55% of expected cases are being picked up. And so this really necessitates different approaches or additional interventions to be able to identify the case deficit. The program has active TB case finding guidelines, especially contact investigations, but these are not routinely or widely implemented in the country, probably due to limited resources. Now, the project I worked for when we did this work with Management Sciences for Health is Track Tuberculosis Activity, or Track TB project. It is a USAID-funded activity that is aimed at increasing case finding and treatment success rates to be able to reduce the burden of TB. And the project really focused on 4 areas: strengthening national level capacity for TB control, implementing an effective urban TB control model in the capital, Kampala, implementing a quality program for management of drug-resistant TB, and also supporting the coordination of implementing partners. So as part of the work with urban TB control, Track TB project engaged community health workers, also called community linkage facilitators, to support the implementation of DOTS in Kampala. And as part of their roles, they would supervise the families to provide the DOT. They would follow up patients that interrupt treatment. They would do the family education as well as contact investigation. So during the period between January and September 2015, community linkage facilitators conducted home-based symptom screening for close to over 3,800 patients that were bacteriologically confirmed. During the same period, they also conducted community TB screening outreaches that were really mapped based on a routine program TB data. And so in this presentation, we compared the yield, the number needed to screen, and the number needed to test between the two active TB case finding approaches. This map just shows how the project uses routine data to be able to target the kind of areas for particularly the community outreaches. As you can see, the red, orange, and going into lime green, the areas that had the highest number of TB patients for the period 2014-2015. And so in terms of focusing the outreaches, those would be the areas where the community teams would go to conduct the outreaches. So in terms of the results, out of the 3,820 index patients, 8,622 individual contacts were screened, identifying slightly over 2,000 presumptive TB patients. And out of those that were evaluated, 147 TB patients were diagnosed. Now, when we compare that with the TB screening, you realize that the teams reached out to a much bigger number of individuals in the communities, 14,000, identified 2,000 presumptive TB patients, and out of those, 63 were diagnosed with TB. We compared these results with the WHO estimates for the prevalence in the general populations, and we could see that with household contact investigation, the yield was tenfold compared to the TB screening outreaches. So this graph shows, again, compares the yield using the two approaches. If you look at the lowermost bars, through contact investigations, I've already highlighted 147 patients were diagnosed compared to 63. Number needed to screen through contact investigation was 59 compared to 222 for community outreaches. And then the number needed to test was 7 for contact investigation compared to the number needed to test to identify a case out of the community TB screening outreaches. I have to note that the number needed to screen here that we realized is slightly higher or almost double the estimated number from systematic reviews. But we think that this could have been due to either gaps in the data collection and the tracking processes during these interventions, given they were done under routine program conditions. And so this is the limitation. There was a lot of learning in this process of doing this work. It was the initial effort that was done to try and increase case finding. And so we know that probably they are recording elements that could have affected the observations we see. Nevertheless, we were able to conclude that really active TB case finding using contact investigation is more efficient compared to the community TB screening outreaches, and we recommend increased investment in contact investigations to be able to close the case finding deficit in similar urban settings. Acknowledgements for the district health team, the health workers, PEPFAR, USAID Uganda, and the Ministry of Health. Thank you very much.
Thank you very much. Within time, we can have 2 or 3 comments, questions.
Thank you very much for this very nice presentation. You said that you showed this nice map showing the TB patients from 2015. And based on that map, you decided where to do your community outreach, right?
Yes.
Well, were the contact tracing areas the same as where you did the community outreach, or was it covering the whole of Kampala district?
Yeah, the contact tracing would cover wherever the patients come from, the whole of the district. For the outreaches, they would go in those areas where there were high burden, the hotspots, to be able to just to focus the health workers and to focus the effort. Yeah.
Clear. And the community health workers, did they collect the sputum samples, or were they referring the patients to a health facility?
Both. The community health workers would collect samples sometimes, but would also sometimes refer some of the patients depending on the logistics available at the time. Yes.
All right, Charles from Nigeria. Please, I would like to know what diagnostic methods do you use to diagnose the cases?
Yeah, for this particular evaluation, we're using sputum microscopy, but for those clients that were found to be HIV positive, the algorithm requires that you do a gene expert test for the diagnosis.
Yes.
I'd like to follow up on one of the previous questions. So you said that some people were referred to a clinic and other people were
had samples collected for.
And then you went back to their homes to give them the test results, or you texted them back?
Yeah, the community teams, because they have the contact information, they would be able to provide the results or be able to call up those that are positive and then take them to the health facility.
So one of the questions I always have for these talks is, of the individuals identified through household contact investigations, what was the rate of uptake of those community to clinic referrals, and what was the rate of treatment initiation? Because if we're finding them, but then they never go get treatment, it sort of kills the whole program.
Yeah, that's a good question, and that's the area I mentioned that the program suffered and struggled with gaps in the data collection. But what we know for sure is that those that were confirmed diagnosed were duly initiated on treatment. But the cascade, we could not track the entire cascade due to the progress, the development of the program. The program was in development.
Yes, Anthony.
Thank you very much for the presentation. Could you give us some idea of the investment in both investment in the contact tracing and the logistic investment in the community screening, so that we can have a proper perspective of which one delivered it properly? Thank you.
Yeah, very interesting question. We did not do a cost analysis of the two approaches, but in terms of, just to give an idea of what happened, is that for the community volunteers or the community health workers that we worked with, they receive a stipend and a transport refund for their daily work. Whereas for the community outreaches, we would need to engage community vans to be able to mobilize the community. You have people moving around, you have local, particularly the local leaders engaged. But also, I need to mention that some of the community outreaches were actually conducted at the time of commemorating the World TB Day. And so it takes a lot more than I could analyze and be able to provide at this platform today. So we didn't do a cost analysis, but when you look at the level of effort that goes in versus the yield is what we based on to do our analysis and reporting.
One last question.
Okay, thank you very much for your nice presentation and also looking at different types of active case finding. Just have a question. I mean, it's very clear that you will find probably or have a higher yield when you do contact investigation, household contact investigation, than when you do a community-based intervention, active case finding. I was just wondering, because it almost sounded as if, yes, the one is better than the other one. Are you recommending just only contact investigation, or is there still also room for community-based case finding, which I would think is the case, especially when you go to hotspots? But I would like to hear your view on this.
Yeah, I think that depends on the availability of resources and time. What we see is that if contact investigation is done systematically and well tracked, we feel, given the limited resources, would go with contact investigation and maybe expand that beyond the patient's household, maybe to a neighborhood and a workplace. So that's what we are looking at. So as a result of our observations, actually, much as it is important to do the community work, we could not sustain the community outreaches all over, and so we continued predominantly doing the contact investigation, but also focusing a few outreaches on those high burden areas.
No, thank you very much. And I think maybe in routine circumstances, I agree with you, Madam, that maybe one size does not fit all. We might want to combine different interventions. We come from settings whereby to get a particular village, you have to walk maybe 5-6 kilometers to another village to get people there. So if you look at the community interventions, indeed, it might not be as effective as the contact investigation, but maybe one size does not fit all. We might want to combine both. But here's a point to say that where we have got limited resources, we might look at the ones that can give us a more yield. And I would like also to agree with Anthony that the issue of cost probably can also give us more advice as we move forward in making these decisions. So thank you so much. Thank you.
Could I now ask Mr. Chao Gogotet to come and present findings from contact investigations in Myanmar?
Good morning. I am Chokret from Myanmar, and it's my great pleasure to be here to present the results on TB prevalent among the individual undergoing contact tracing and its determinant in Mandalay City, Myanmar. This is the collaboration result between the Department of Medical Research and National Job Research Program in our country and Prince of Songkla University here in Thailand. Myanmar is one of the 22 global high TB partner countries with a prevalence of 473 per 100,000 population. A meta-analysis in low and middle income settings showed that the prevalence of the TB among the household contacts varied between 2.1 to 10.1%. Contact tracing for TB is recommended worldwide, but in Myanmar, also the policy of the contact tracing has been adopted, but there were no routine data showing whether contact tracing was completely investigated or how many results were positive. The objective of this study was to assess the prevalence of TB among the household contacts by using chest X-rays, pseudomeas, or gene-expert technology, and to determine the determinants of TB in Mandalay City, Myanmar. A cross-sectional study was conducted in Mandalay City, Myanmar, with a densely populated area with a higher TB prevalence. There are 7,007 TB centers in this city, and the TB prevention and control is mainly based on basic finding strategy. Regarding the study sample, we included all registered pulmonary TB cases currently seeking the TB treatment from August to November 2050. For the household contact, we defined that all family members living with the TB patient in the same house for early treatment before registration of TB treatment were included in our study. In the sample size, we included 40 inter-TB cases, and they are respected all household contact 174 were included in this study. For data collection, we've randomly selected the inter-TB case from Township TB register, and then we get the informed consent from each and every inter-TB patient household contact. We arrange the interview, and then we perform the sputum collection at the inconvenient times. We suggested them to go to the chest X-ray facility and gene expert. The figures show the procedures of the contact tracing in different age groups. We define the organ variable at the positivities of the household contact if they are in the following condition: positive sputum, positive chest X-ray, or positive MTB, both in expert MTB-IS test. For independent variable, we only consider in the household contact. The figure shows the distribution of the positive TB among the household contact in Mandalay City, Myanmar. The case were highlighted at the red spot. Here, we can see all positive TB cases were scattered without any specific pattern. All contacts we are living within the 2 to 10 miles away from the chest area center. Firstly, we encourage them to go to the chest area facility in their own way, but no one went voluntarily for chest area during the contact tracing. Therefore, we arrange the transportation for them to get the chest area facility. Among the all household contact 174, the contact age 50 and above were 115. In this group, we perform both student and chest area. The positive student was 77.8%. It was overlapped with the chest area result. Finally, we confirmed by using the gene expert test. Therefore, the prevalence of the positive TB in this group was 12.2%. For the contact age less than 50 years, it was included 59 contacts. In this group, we only performed the chest area. The prevalence of the positive TB in this group was 60.9%. Therefore, the overall prevalence of the positive TB meant the contact tracing was 30.8% in our study. This table shows the determinants of the positive TB in contact by multivariate analysis. The factor significantly associated with the positive TB were household contact who take the care to enter TB cage, who had the smoking, drinking, and passive smoking habits. Regarding the discussion in geographical medicine, all contact does not voluntarily test for the TB treatment. There were no geographical barrier for accessing to TB case, but our health system need to put them more effort to get their complete contact tracing. The prevalence of the positive TB in our study, 30.8, is higher than the study from China, Nepal, and Laos. Because in our study, we was more rigorous and closer follow at the all contact. We used the 3 different methods in combination, chest area student and gene expert, regardless of sign and symptoms of TB. In conclusion and recommendation, TB prevalence among the contact was high. Caretaker to TB patient smoking, drinking behavior were almost combined in positive TB contact. We need the logistic and financial administration to strengthen the contact tracing strategy of the country. Thank you. I would like to turn to the FIC and NIH branch and epidemiology unit and township medical officer from Manly City and Michaela Thompson, study director from United States, for helping us a lot. And I would like to thank the union organization to support me to have a chance to represent my abstract in this conference. Thank you a lot.
Are there any questions? I have one. I wondered, did you collect information about the presence of signs and symptoms in the contacts that you tested?
Yeah, actually, we also collect the presence of signs and symptoms TB, but we had the second analysis for this signs and symptoms TB. In this signs and symptoms TB, we only found the 80 TB case. Is it the half of the prevalence? Yes.
Okay, so if I understand correctly, you may have found quite a few asymptomatic TB cases among the contacts that would not have been detected if you had screened by signs and symptoms. Is that correct?
Yes. Although we had the interview for the signs and symptoms, but in this year we only just show the chest area examination and then change by technology. Yes. Okay. We do not show the data here.
Okay.
Yes, I collect it.
Any other questions?
Yeah, Knut Klarner from WHO. Thanks, great work. I'm just wondering, with this incredibly high prevalence of TB among the contacts, maybe you showed it, but I missed it then. What was the proportion of clinically diagnosed TB among the total?
I'm not sure.
Can you put the slides back?
Okay. Yes, you can see that clinically diagnosed TB in our study. We had the 2 groups, and we had the 2 groups. Yes, in 50 years and above, we can get the clinically diagnosed TB cases are 12.2%. For the less than 50 years old, we only perform the chest X-ray, so we cannot say this is the clinically diagnosed TB. We only just.
So the 14 are, it's not clear, the last box is saying expert, 14 out of 70.
Yeah,
so
yeah,
these
yeah.
are positive and expert.
Yeah, positive, but this is the final confirmed diagnosis for the all positive TB.
So they're all bacteriologically confirmed?
Yeah, all bacteriologically confirmed TB case, this one is.
Oh, okay.
Can I continue a little bit on this? Because I also had a question around that. Lucy Block from the KIT in Amsterdam, by the way. I didn't introduce myself earlier. What I didn't get, maybe you presented it also, but I missed it maybe. Which percentage of the household contacts that were identified were also screened? I mean, were all the household contacts that have been identified also screened, or did you miss quite a number of them?
No, in our study, we try to include all household contacts to investigate. Yes.
And so you were able to get them all to come for a chest X-ray and for the sputum test.
Yes.
So this is 100% coverage.
Yes, 100% coverage for all households.
Then it's indeed very high.
Yes.
Great, thank you very much.
Thank you.
And if I could invite our final speaker for the session, Mei Mei Kwan, to shift gears a little bit away from contact investigation and discuss TB among immigrant workers from highly endemic countries following pre-entry screening in Taiwan.
Distinguished guest, dear colleague, thank you for this opportunity. Offer this opportunity. My talk today is about the screening program of immigrant worker in Taiwan. Excuse me. Next one is this one. In industry countries, tuberculosis cases are concentrated among immigrants and driven by reactivation of latent TB. To respond to this risk, many countries screen immigrants from active TB, and some countries also screen for latent TB. Taiwan immigrant TB control policy aims primarily to screening active TB cases through chest radiograph for prevention. Taiwan is an intermediate tuberculosis country with approximately 50 per 100,000 people's TB cases, and most of the TB cases was aged over 15, and the average annual immigrant worker population is about 400,000. In Taiwan, the admission criteria for 3 years residency of new immigrant worker from highly endemic country is an overseas pre-entry normal chest rate approval. Then all immigrant workers are mandatorily followed by 4 rounds of screening. Those TB positive cases were not allowed to enter or remain in Taiwan during 2011 to 2013. However, the policy has changed. Only the multiple drug-resistant TB cases were repatriated. So this study was aimed to analyze TB burden among immigrant workers under such policy and evaluate the screening effectiveness. Data was obtained from the National TB Registry Database, which was a web-based nationwide notification system. And to stratify the TB case finding by active post-entry screening or passive surveillance. The number of insurance was linked with the database of National Immigrant Worker Physician Examination database to obtain the detail, screening date detail. To estimate the TB burden, we used the cumulative instance, which was include those cases detect within post-entry 3 days, which might be the prevalence cases. Results. So the immigrant worker was most aged between 20 to 40 years old. The list, and with the instance about 100 per 100,000, which was 2 to 4 for the higher TB instance than the then the corresponding age is the domestic Taiwanese. In parallel, the fluctuation of TB incidence among immigrant workers of each nationality in Taiwan was significantly associated, was positively associated with the WHO estimate in their original countries. This figure demonstrates the 9 chart demonstrated the fluctuation of TB instance. You can see there's no significant difference between the policy of the repatriated TB cases before and after 2014. And you can see the population and the incidence with an increased trend in the Indonesia, the slight decline in Vietnam. This was the clinical diagnosis correct outcome. Most cases was sputum smear negative pulmonary TB case encompassing 74%. This demonstrates the clinical correctness of passive identified cases with a slight higher odds ratio of smear positive cases. About in terms of the effectiveness of active screening, this figure can show you each year's fluctuation of the screening year, and we can see that only in 2040, in the 3rd round and the 4th round, we hear the TB cases was larger than the cutoff value, and the positive predicted value is about 52. So under this, is it time? My conclusion is the current mandatory post-entry screening programs for TB could actively finding 41% of TB cases at early stage and reducing potential transmission. The entry worker with normal chest rate from highly endemic countries will sustain a high TB incidence, which might be due to reactivation of late TB. So consider so we might recommend to incorporating LTB screening, the ITP, for immigrant worker from TB highly endemic region might be next step. Thank you for your attention.
Thank you very much. Yeah, we open the floor for questions, comments. Yes, sir.
I'm Dr. Subrodo from Kenya. I have a question. Like you mentioned, the pre and the post testing of the migrants comes to something around 41.1% of identification of TB among them. Okay, so my question is that what is the percentage of TB that you find in the pre-entry of these migrants, and what is the percentage of TB in the post-entry migrants? I mean, if I understood from your presentation, you are saying that you do the screening test when the migrants enter the country, and then when the migrants go out of the country. Is that so? Or did I miss something?
Actually, I only collect the data post-entry. The pre-entry screening, that is over-screening data was not included in this study. The study period was only focused on the post-entry, following the pre-entry, just the 4 rounds of post-entry.
So if I can ask you then how many days or how many months after the migrant has entered the country, you went in for this screening? Because then it might be a question that, did they pick up the TB within the country, or did they bring it from outside?
Yeah, maybe
about 100,000 each year was newly entering, and the cumulated stay and the stay in Taiwan is about 400,000.
The zero-day entry should be completed within 1 week after their arrival. But pre-entry has only been done in their own countries, but we don't have that. We don't have that data.
So which one was higher, post-entry or pre-entry?
We don't know the pre-entry part.
Oh, we don't know.
Yeah, we only can control the post-entry part. Yeah, because we don't have the, like surgical, like national surgeon, like United States. We don't have that, so we don't. Yeah.
Thank you.
Just wondering, have you calculated the incidence of those that were free from TB at the first screening? Because in effect, you, if I understand correctly, you have a cohort of migrants entering, you screen them at entry, and those that are negative, you can follow through the registers, right? So have you calculated what is the incidence in different groups, and does it correspond to the estimate in their home countries?
It was in a parallels positive association. The incidence was, however, was lower than their original country. I think it maybe this was following the overseas screening and already repatriate the loads of positive cases.
All right. That's another question. Yeah, please, you have time.
Yeah, thank you. I think this is also fascinating and a very special case that you're also presenting here. I got the feeling, and I wasn't completely sure what exactly the outcome was, but that you're also comparing what happened in terms of the screening and the outcomes of the screening in the period until 2013, where you still had a policy that anyone who would, if I understood it well, who would have been positive or found with TB was repatriated to their home country. Is that right? And then after 2014, or as of 2014, that's no longer the case. And I got the impression that you're trying to compare also the outcomes of your screening and the effectiveness of your screening under those two policies. And what I didn't get then, if that's the case, what exactly you found as a difference? Is it more effective now than it was before, or does it not make any difference? Sorry, do you understand my question?
Those cases being repatriated, some of them was not reported into the TV registered database. However, they will record on the physician examination database of the immigrant worker database. So after we linkage these two data, we can get the detail of the exactly TB cases.
I don't know if we have. I think the current policy is different from the first policy, because once they could get a TB patient, the way I've understood was that they are repatriated, and therefore it was difficult even to come up with treatment outcomes for those ones. Now the current screening criteria, I'm not sure if we can compare this and the previous one, because maybe you don't have the data. I don't know if I'm also understanding you correctly.
I think that she really wants to know whether the difference between 2013 before and after 2014, but I think 2014 is too early. Yeah, we still see a little bit difference, but we need to follow up whether it will change the situation. And I think it's better for them that they can stay to complete the treatment. Yeah.
Thank you. All right, I think with that, we will close our session. I'd like to thank all of the speakers. You know, the Global Report has estimated that there are 4.5 million missing cases of TB each year that are missed by health systems, and I think the session has provided some interesting experiences discussing delays in care, reaching out to communities, engaging the private sector, improving contact tracing, and conducting screening among migrant populations, all of which may help us to find some of these missing cases. And thank you very much, all of you who have attended, and thank you very much to our speakers.